hope to have a great dialogue together and hopefully inform everyone about COVID and heart disease. Before we get started, just a couple of things. We want this to be interactive, so if you have any questions, please put them in the comment box, and we'd love to respond to them if at all possible. Tonight, we want to highlight several things. First of all, we definitely want to highlight a little bit about HonorHealth and its Cardiovascular Center of Excellence. We are very proud of physician leaders like Dr. Rahul Doshi, who have been physician scientists that have advanced medicine, patient care, patient quality over the last few years, particularly in the cardiovascular realm. We've received significant notoriety in the past in regards to this Cardiovascular Center of Excellence, and have actually advanced patient care in several realms, including the treatment of lower extremity blockages, in the treatment of heart disease with novel technologies and stent technologies, as well as more recently with the advanced techniques and technologies that have advanced care in the patients treated who are dealing with COVID and its catastrophes. But with all that in mind, the reason why we're here tonight is because February is Heart Month. And so Heart Month, as it allows us to bring awareness to cardiovascular disease. Unfortunately, heart disease remains the #1 killer of both men and women in the United States today, with nearly about 700,000 people annually dying from heart disease. This means that heart disease truly is the #1 killer of both men and women, and heart disease leads to more deaths than all forms of cancer combined, including breast cancer. In fact, nearly 1 in 4 of us will die from heart disease, unfortunately. So with this month, we really try to focus on awareness because nearly 50% of all heart disease could be prevented with more proactive treatment. And so traditionally in February and Heart Month, we would be talking about high blood pressure, about high cholesterol, and things like that that can really help to reduce your risk for cardiovascular disease. But this year is different than all other years. Unfortunately, COVID has really impacted the way we treat patients, how we are dealing with our loved ones, our families, and things of that nature. And so we wanted to do something special tonight and really talk about COVID and heart disease. And so I want to introduce again my colleague, Dr. Rahul Doshi. So Dr. Doshi is an internationally recognized electrophysiologist. He's been published in several high-profile journals, including the New England Journal of Medicine. He is a pioneer in the treatment of advanced abnormal heart rhythms and atrial fibrillation. And more than that, he's a great friend and colleague and mentor who's really been pushing the hospital on advancing our care of patients with COVID and COVID cardiovascular disease. So Rahul, thank you very much for joining me here tonight.
Well, thanks for having me. It's a pleasure, and especially speaking to all of you. Of course, this is, as Dr. Shah just stated, this is a very different year. So instead of focusing on hypertension and high cholesterol and even coronary disease, even specific arrhythmias that are very common, I think everything is COVID these days. And it's fascinating to me how much COVID and cardiac disease seem to be very intimately related, more so than we've seen with every other, certainly viral or infectious etiology, and how much this is really has the potential to affect how we practice cardiovascular medicine in the future.
So as a physician, we've been impacted by COVID in several ways. When I go to the hospital, we're all wearing masks, so sometimes to the point where we don't even recognize each other. When I come home, I take off my scrubs in the garage to make sure that I don't accidentally transmit COVID to the family. But I think what hit home to me the most was a few months ago when I walked in and was taking care of a patient in the ICU at one of our hospitals here who was 30 years old and didn't have any pre-existing heart disease or conditions. He wasn't obese, he wasn't a smoker, and he had come in with COVID pneumonia, and unfortunately his breathing deteriorated to the point where he was on a breathing machine and they couldn't get his oxygen levels up. So they asked us to come by and see him, and we did an ultrasound of his heart that showed that his heart function was severely depressed or declined. In fact, he was only pushing out about 10% of the blood that was in his heart with every beat, when usually you should be pushing out about 50 to 60% of his blood.
That's right.
So the physicians at HonorHealth put in an artificial pump to help allow him to hopefully recover from COVID. But unfortunately, he developed more blood clots in his lungs and across his body and died. And it was stunning to me that a 30-year-old who didn't have any other pre-existing conditions had so many problems from COVID, and specifically COVID causing problems with his heart and his cardiovascular sort of system. So just starting there, just to give our audience a sense of how COVID can impact the heart, what have you seen the most in sort of the short-term acute situations of patients who are coming into the hospital with COVID? How does it impact the heart?
Sure. So as everyone is aware, certainly today, COVID is caused by this novel coronavirus. So it's a viral infection. And we know that viral infections, and some in particular, certainly can affect the heart by causing either a direct cause of inflammation of the heart, or it can certainly predispose to many other things, such as heart attacks, such as blood clots everywhere in the body, including the lung, including the heart, including the brain. It can cause your body's own reaction to the heart, where your own immune system actually attacks the heart. And all these mechanisms are in play with COVID, but much more so than essentially every other virus or viral infection we've seen. And so certainly we have seen, all of us have now taken care of patients who have had acute manifestations of cardiovascular disease associated with their acute COVID infection. And that can be anywhere from a severe decrease in cardiac function, as you've described, caused by this inflammation of the heart, what we refer to as myocarditis. It can be caused by acute heart attacks. It can be caused by a variety of mechanisms that in total lead to this acute decrease in function. It can manifest as cardiac arrhythmias or electrical disturbances of the heart. And certainly when you're just sick in general, when your whole body is fighting this overwhelming infection, the heart itself can react to that and just get weaker. So we've all seen that on the acute phase. The terrible thing about this in relation to the heart is just how common it is and how many different ways it can actually affect the heart.
Yeah, absolutely. I mean, what I've seen the most is exactly what you're describing. People with congestive heart failure who basically have a weakening of the heart, people who have an abnormal heart rhythm, which you are a specialist in treating, people who have come in and have blood clots. And then two other sort of strange things that I've seen quite a lot of recently, something called the broken heart syndrome, where people are so stressed in their body from COVID that they end up having the manifestations of a heart attack without the classic heart blockage that we can sometimes see.
Right. So this otherwise known as Takotsubo's cardiomyopathy, this is something that we see in other patients with other acute illnesses, but it just seems to be more common with this for whatever reason. And it's going beyond the patient who is very, very ill and just an acute reaction, whether it's an overwhelming infection or some other catastrophic catastrophe to the body where the heart then reacts to. There seems to be something that's much more unique about these infections and its predilection to affect the heart. We've seen this even in the early days of the pandemic, the data from Wuhan, the data from many other places in the country, that there was an especially high incidence of this cardiac failure or inflammation of the heart as manifested by the decrease in function, as manifested by chemical serum markers that we can measure for that demonstrate injury to the heart, to the point where even up to 2/3 of patients who are hospitalized with COVID or end up unfortunately passing away by these overwhelming infection, can have these manifestations. But I'm also fascinated by the fact that there's so much more that we're learning as time goes by and the effects long term that these things can have.
Is there any particular situation where you've seen somebody have COVID, recover from it or not recover from it, and then have long-term consequences from it? Or is it always, if you're going to have problems with your heart, you're going to see it when they're in the hospital with COVID?
So I think that, well, obviously we have patients that have those manifestations acutely in the hospital. And those patients, yes, not only are they associated with a poor prognosis, or hopefully they survive and get out of the hospital, but they do have a decreased likelihood of doing so. But the ones that do seem to completely recover, they still have a higher incidence of manifestations from a cardiac standpoint. These chronic manifestations we have seen, and it's an absolute misnomer to think that it's only present in folks who are older or have other comorbid disease such as hypertension or diabetes mellitus, certain ethnic groups. It's certainly the case for the acute fulminant illness, but this chronic illness does not seem to have, at least from what we've demonstrated, any particular predilection. You mentioned a particular patient that I've treated, and you have as well. We've had a particular patient that actually was a highly trained endurance athlete, an Ironman triathlete, who developed acute COVID infection, had manifestations of acute COVID infection, including inflammation around the heart, including electrical abnormalities of the heart acutely.
And this is somebody who really hadn't been sick any time before.
No history of any prior illness in his entire lifetime. Completely healthy, obviously a highly trained athlete, someone who we would consider and the absolute picture of health. But unfortunately, he seems to have recovered, and this gets to your point. You were asking, okay, cardiac function might be compromised acutely associated with the acute infection. Okay, other manifestations of the disease, such as electrical disturbances or heart failure or just recovery from the infection in general. But what we've seen that despite a recovery in cardiac function, by any way we can choose to measure this, he still has had manifestations. And when I say manifestations, profound clinical responses, including just the inability to really exercise, certainly at the level that he was accustomed to before. Someone who, could do an Ironman can now, several even months and now even longer, can only fast walk, for example, despite seeing recovery in that squeeze of how that heart pumps.
Right.
And then other manifestations chronically, including some of these electrical disturbances that have plagued him since he has recovered from the acute COVID infection.
So I want to get to the electrical issues in just a minute, but just for our patients who are coming to the hospital with COVID and have heart disease, do you think our treatment has actually advanced over the last 10 months? Has it improved?
So there's no doubt that overall, and I'm sure the audience is well aware, that our fatality rates associated with the COVID infection do seem to be decreasing. And that's great news. That's great news for everyone. How much of it is related to the virus? Because as everyone is aware of, the virus is changing over time. We do not see the same degree of fulminant illness that was first described in the East Coast with these high fevers and catastrophic circulatory collapse and profound inability to get oxygen through the lungs. But at the same time, we don't know that any particular therapy that we're doing as far as the heart is concerned has really made any difference. What we do know is that some of these therapies, whether it's some forms of convalescent plasma or antibody-directed treatments, some forms of antiviral treatments, have been associated with decreased hospitalization in the very sick patients. We clearly know that steroids acutely does seem to decrease the degree of fulminant illness.
That seems to be the most promising
absolutely.
advance.
And so that's very clear. Some of these other treatments, such as hydroxychloroquine and such, have really not panned out. And many other actually targeted antiviral therapies haven't really panned out. We've certainly gotten better as far as our management of these patients acutely, at least for the pulmonary illness. Right? It actually is, we've actually learned that we want to try to hold off on placing patients, giving them a breathing tube to support their ventilation unless it's absolutely necessary. And certainly we have made significant advancements in our ability in the critically ill patient with circulatory collapse to do things that are heroic. Whether it's the utilization of these artificial pumps, there's something called ECMO, extracorporeal membrane oxygenation, that HonorHealth is actually
One of the
front
first in
and
the country
centers,
to actually utilize it successfully.
Absolutely, and with a very high success rate overall compared to our colleagues across the world. And so certainly these advances acutely, but we don't know whether we're doing anything regarding the chronic management of these patients.
So if we go beyond the hospital here for a second and we go to what you and I typically see in the office. So I have a lot of patients these days that are coming to me and seeking care after having COVID. And one of the questions that they oftentimes ask me is, for what sort of tests will we do? How can we figure out whether COVID is impacting the heart? And usually what I end up doing is 2 tests at some level if I'm suspicious that COVID could be causing some cardiovascular or heart and vascular issues. One is an echocardiogram, which is an ultrasound of the heart that will allow me to see if the heart has any dysfunction or any inflammation sometimes. And then another is called a Holter monitor, a monitor, or an event monitor, which will really allow us to see if there's any abnormal heart rhythms. And in the case, and then when we see something that's abnormal there, then we can sort of react to it. So I want to go back to that situation that you and I were talking about, a patient that we truly have really been mystified by and intrigued with respect to how COVID has impacted his heart. And so we've got a picture of him here, actually, definitely an avid athlete previous to all this happening, and then all of a sudden having some issues. So if I recall, he was having symptoms that didn't make a lot of sense a few months even after his COVID illness had transpired. You want to walk us through what we did?
Sure. So again, and you can see here's a guy who's an amazing athlete who recovered from COVID for all practical purposes. He did have evidence acutely of heart manifestations. He had some arrhythmia issues and electrical disturbance of the heart that can be caused by inflammation around the heart or in the heart muscle itself. But for all practical purposes, he had evidence that his cardiac function essentially had normalized. And just by the tests that you described, and certainly as screening tools, either doing some sort of ambulatory heart monitor to monitor for the heart's electrical problems, and certainly an echocardiogram in any patient who you suspect with any kind of chronic manifestations, I think is generally accepted as standard of care.
But I remember correctly that, though his ultrasound of his heart looked okay, both you, the patient, as well as his primary care doctor were still suspicious that something was going on.
Absolutely.
And so you went a step beyond. What did you do?
Well, I mean, so as you mentioned, he had continued symptoms. Despite having evidence of normal function, he continued to have shortness of breath, the impaired ability to exercise, and just actually chest pain. Not the same kind of pain that people would have in having an acute heart attack, but just more of the vague sort of chest discomfort, but also can be with exertion. So he had these manifest symptoms of chest pain, and he had the continued electrical problems. And to me, when I see that in a patient who's recovered from COVID infection, you have to be very suspicious of this chronic inflammation that can affect the heart related to the COVID infection, what we call myocarditis or pericarditis or myopericarditis, which is a combination of both. And this is essentially the classic hallmark of chronic cardiovascular disease in patients with COVID infection. And so there are some
what are you seeing? You're seeing inflammation or what?
So the idea is to try to demonstrate that or prove that if that's your suspicion. So certainly already by symptoms, you have an idea. Certainly with manifestations that are clearly objective, somebody like Derek was having lots of recurrent arrhythmia, electrical disturbances of the heart that could be consistent with inflammation around the heart. But there's a more detailed study, a more exacting study that can specifically look at inflammation around the heart. And the patterns that we see, the type of scarring, are very characteristic of these infections.
So you're talking about a cardiac MRI?
I'm talking about a cardiac MRI is a cardiac magnetic resonance image. And this modality gives us the most detailed look of the heart or the heart muscle and the sac that the heart sits in. And you can see evidence of inflammation.
I got a picture here for you. Yeah.
That's exactly right. And so it gives us very careful looks at the actual heart muscle itself, and you can actually identify areas of scar or areas of inflammation in the heart muscle itself that are consistent with the diagnosis. So for our patient, yes, I ordered a cardiac MRI scan, and yes, it was consistent with the inflammation of the heart itself.
Okay. And then you had noticed an abnormal heart rhythm as well. Is that pretty common that you're seeing this in COVID patients?
So we are seeing a whole host of electrical disturbances with COVID, but the mechanism of these things is highly variable, and I'm not sure that you can say one in particular. So for example, we initially thought that in the acute period of the illness, that it was acute inflammation of the heart muscle that was actually causing patients to be predisposed to lethal cardiac arrhythmias that essentially cause sudden cardiac death, where the heart itself goes into such a chaotic electrical storm that it can no longer pump. And if it can't pump, obviously not consistent with supporting life. We saw that acutely in the hospital when patients were critically ill, that was associated with this inflammation and the decrease in cardiac function. But what about long term? We're not seeing a signal, even though it was initially suggested that patients recovering from COVID had a higher likelihood of having these type of fatal events. Well, that actually is controversial because some patients certainly can manifest as having other things such as blockages in arteries causing acute heart attacks. Patients also aren't seeking medical attention, and so that's affecting the rates of having these type of catastrophic events. But what we are clearly seeing in these patients are these common arrhythmias in the upper chambers that seems to be related to this myocarditis or myopericarditis.
Okay.
And that we know is a classic finding that is associated with these type of inflammatory abnormalities. And so Derek had recurrent what's called atrial fibrillation and atrial flutter. These are both rapid electrical rhythms in the upper chambers of the heart. They are classically seen or associated with inflammation around the heart or pericarditis. They are different. Atrial fibrillation is the most common arrhythmia in the world. It's something that we spend a lot of time treating and developing our understanding of.
And it's dangerous, right? Because it can lead to blood clots that can go to the brain
in
and cause
patients,
a stroke.
Absolutely. The most catastrophic poor prognosticators with atrial fibrillation is suffering a stroke or suffering heart failure, and atrial fibrillation can cause both. Atrial flutter is similar. It's also a rapid electrical rhythm, but it's an organized circuit. And thus, it's a little bit different in both their response to medicines and the response or the ability to treat this more definitively. So without getting into a lot of detail, atrial fibrillation, of which we do treat on a daily basis as part of every arrhythmia specialist practice, is something that is targeting sort of the things that initiate atrial fibrillation or the things that maintain it, but it's not targeting a specific circuit in most cases, as opposed to atrial flutter, which is. And in patients...
And the whole field of electrophysiology, which is what you represent, has done a tremendous job in the last decade of being able to treat these abnormal heart rhythms with a technique where you can go inside the heart and actually ablate or get rid of it. In the COVID patients, is that possible? So
the answer is really, I don't know, but in some cases, certainly. Like everything else in medicine. So we certainly try to use medications first, and we certainly did in Derek, actually. So again, I mentioned he had both atrial fibrillation and atrial flutter. So we placed him on medicines that essentially treat both protecting him from the risk of having a stroke and trying to control the heart rhythm itself. And I think the big thing that's the unknown is if there's an active inflammatory process, should we go in and do an invasive procedure? And I think most people would argue the answer should be no, because it might just get better on its own. But Derek was continuing to suffer through these symptoms and had repeated episodes documented on multiple monitors of recurrent arrhythmia associated with very fast, very irregular heart rates, decreasing in how his heart was working acutely when he's in the arrhythmia, causing him profound symptoms. The medicines controlled one of the rhythms, but didn't control the other one. The atrial flutter rhythm is what I'm referring to that's difficult to treat sometimes with medicines, but it is very amenable to an ablation procedure where we go in with small electrical catheters to the heart and we actually buzz the critical circuit that's causing the abnormality. And so this is what we ended up doing.
And I've been really impressed in some of my patients who have had that it's been life-changing to such that they could come off medications and really go back to the quality of life that they wanted to live.
Well, that's certainly the case for many of our healthy patients, and that's the goal of these type of treatments, to essentially restore them to normal function and normal life, and that includes medicines. But these patients with COVID, especially ones with continued symptoms, the so-called long haulers who have chronic symptoms. And so in Derek's case, it's now going on 11 months. We are hoping that he continues to improve and the tendency goes away. We've taken care of one definitive abnormality by ablating the atrial flutter, and that's successful. And now we're controlling his arrhythmias, but we're continuing a medicine. And if you ask me, do I think we're going to need to do something for the atrial fibrillation? The answer is I don't know, because we're just continuing to wait and see.
Okay, well, fascinating. I have a couple other sort of things that come up in my world quite often I wanted to ask you about. One of the questions that really does come up frequently is that many of our friends and family members have had COVID. And as a cardiologist, they oftentimes ask me, does that mean I should go get checked out? And so what are you advising your own family and friends to do if they've had COVID? Should they seek professional guidance from a cardiologist, or should they base it based on symptoms?
So the answer is, I think, yes. And so on a personal note, right, I guess as a cardiologist, I've actually suffered through acute COVID infection, recovered for the most part. But I also had actually long hauler symptoms of myopericarditis, inflammation around the heart. I was able to recover and my symptoms are largely gone now, now 7 or 8 months out. And so it makes you wonder. And so in seeking medical attention, should everyone, for example, get these sophisticated imaging studies, the cardiac MRI? Should everyone be monitored? And I don't know that that's right. But I do think that patients who have the symptoms or some objective finding that suggests cardiac involvement absolutely should see a cardiologist, cardiac specialist, a heart specialist, and have a basic workup.
Okay. Yeah, my own perspective has been that in general, if you were having any symptoms, then for sure you should go see a cardiologist. I think the jury's still out. I'm not sure we know for sure whether everyone should be evaluated.
That's exactly right.
And I think the long hauler syndrome is very fascinating to me. One of the most interesting things that I've read, and I think all of us have been reading more as we've been trying to understand COVID. It's a brand new subject that none of us trained in medical school or residency or fellowship or any of our advanced training. So it requires a lot of learning. And I think one of the most interesting things that I saw was at Stanford and UCSF, they did a study with an institute that they were associated with, where they actually had live heart cells, not inside somebody's body, and they infected it with COVID. And they could see that the COVID cells became disarrayed. I mean, the heart cells became disarrayed when they had COVID, such that they were no longer in a linear fashion, but were actually in some sort of uncoordinated, sort of disarrayed fashion that really could be part of the issue that we're seeing with long hauler syndrome, although the jury's still out and we don't know.
It's a fascinating topic. This has gone back and forth as far as the mechanism. Does COVID directly affect the heart muscle, as you're sort of describing? Does it affect the blood vessels, the small, tiny blood vessels that are in the heart muscle? And really, that's the etiology. Does it do other things, including affecting your body's own, what we call the autonomic nervous system, the things we don't think about, involuntary nervous system?
So you and I are both big basketball fans and
yes, indeed.
Sports fans in general. And so and then we have kids that are wanting to participate in sports that sometimes have had COVID. what is going on with COVID, with athletes that have COVID and their ability to go back to doing the vigorous exercise that they want to do? What's the most recent guidelines, and what are opinion leaders like yourself advising patients to do who have that particular situation?
My sighing is, of course, because do we have a great answer for this? Certainly, it's been recognized that, as we've discussed, that COVID can affect young, healthy people. And it can affect people that are asymptomatic. There's been several studies that have actually imaged patients, athletes, who have recovered from their acute COVID infection, many of them asymptomatic, who had evidence of inflammation on their cardiac MRI scans, with a fairly high percentage, more than half, which is obviously frightening. Mm-hmm. But what does that mean long term? Is that the case for any viral infection? And the answer is we don't know. On one hand, this is now becoming the most studied virus in the history of viral infections, but there's so much that we just don't know. Obviously, if patients have the decrease in cardiac function, and anecdotally, it was observed early on in the pandemic that patients recovering, going back to vigorous exercise, actually was associated with rebound symptoms. And there's been some thought that actually pushing exercise can actually lead to then this increase in the tendency of inflammation around the heart, contributing to persistent symptoms in these long haulers, right? And so, but in a patient who has normal function and is now completely asymptomatic, what does that mean? We're going to hear more and more about this. There was recently that kid in Florida who
was playing
basketball. He's an NC2A, Division I athlete in basketball, very promising career, and had a catastrophic event on the basketball court. And he fortunately has recovered. Now what? What does that mean now long term?
Yeah, so when we've been seeing athletes in general, many of them have had prerequisites by their colleges or teams that they need to have a blood test to make sure that there's no inflammation that remains in the heart, or called a troponin, as well as a Holter monitor to make sure that there's no abnormal heart rhythms that are persisting, as well as an echocardiogram or ultrasound of the heart, just to make sure that there's no inflammation that's being seen in the heart or dysfunction of the heart. So, and I think definitely there's just more studies that need to be done. Fortunately, or unfortunately, there's going to be a lot of subjects that are available to do that, as many people have been inflicted with COVID. I think there's a lot of questions from the audience, but I want to ask you a couple that have been on my mind for a little bit, that my mom and dad asked me. With respect to the heart and heart studies, is the vaccine at all dangerous?
So just like I mentioned that COVID itself is becoming the most studied virus in the history of viral infections, the vaccines that we're administering clearly are the most studied vaccines in the history of vaccines, just because of the sheer numbers. And so even the vaccines that are approved for usage in the United States, the Pfizer vaccine and the Moderna vaccine, there is literally data from hundreds of thousands of patients, and they do appear to be acutely safe. Do we know that there's any long-term manifestations? Obviously, we can't say, because we just don't know. We need that longitudinal data. But acutely, the vaccines appear to be very, very safe. So, I mean, the answer is I would encourage everyone to be vaccinated.
There's obviously in the United States, we have Pfizer and Moderna, and you've read international studies about AstraZeneca as well as potentially Johnson & Johnson. From the cardiovascular perspective, is there any unique advantage to either?
We have no idea. What we do know is that all of them, obviously, there's been some controversy regarding the AstraZeneca-Oxford vaccine related to variants. But these vaccines are incredibly effective at decreasing the likelihood of being acutely ill, certainly hospitalization and death. And so does any of them in particular have a particular protection for the heart? We have no idea.
Okay.
We have no idea.
Well, let's get to some of the questions that people have been emailing or sort of buzzing in on that YouTube video right now. I think we put up a few of them here just right now, actually, as it is. So one of the questions is, I think we already addressed this, does everyone who has COVID-19 need to see a cardiologist? And I think both of us think, in general, if they have symptoms, for sure, and then the jury's still out there as to whether everyone needs to see a cardiologist.
Yeah, I think the answer to everyone is that's likely impossible and is probably not necessary. But anybody that has any symptoms, whether it's chest pain, whether it's difficulty breathing, whether it's a feeling of skipping or pounding in your chest, palpitations, they should seek evaluation from a cardiologist.
Absolutely. So that goes to another question that came in. If I am having symptoms, what do I need to do next? And so I think you just addressed that right there. Go see a cardiologist, go see your primary care doctor.
And I think if you're having any persistent symptoms, and obviously we are learning a great deal about the huge variation in chronic symptoms in long haulers. Some of the best sources of these informations are some of these online communities, which are actually the medical community is learning from folks who have recovered. Because obviously early on in the pandemic especially, we were encouraging folks with less severe symptoms not to seek medical attention, right? And so there was a lot of things that we were delayed in learning about, and we actually needed the public to educate us in this regard. But any kind of persistent symptoms, I would seek medical attention, absolutely.
I think that reminds me of something actually very important, in that COVID seems to have many impacts, including causing congestive heart failure or heart weakening. It can cause abnormal heart rhythms. It can cause inflammation. It can cause a stress-induced heart attack. And unfortunately, it's caused one other big thing, and that is it has caused people to delay treatment or preventive care for other things. There was a study that came out, I think that you highlighted to me, that nearly 30 to 40% of people actually have missed out on their preventive care wellness visits because they were worried or apprehensive about going to doctor's visits. But even more dangerous is that about 15 to 20% of people, even with severe symptoms like chest pain, have not gone into the hospital. And the problem with that is that obviously it can, if you delay your treatment for a cardiovascular disease, you can end up having more severe permanent damage from heart attacks, more severe permanent damage from these abnormal heart rhythms. So I think it's a big deal. So I would encourage our audience and colleagues to definitely make sure that if you have any symptoms, definitely go seek care. What do you think?
100% agree with that. I mean, and I mentioned earlier that we initially thought that there was a signal that the viral infection itself was associated with an increased risk of sudden cardiac death. And that has been since mostly explained by this not seeking medical attention at a normal sort of interval, or having a much higher threshold to seek medical attention because of fear of getting COVID infection. And so, no, you can't ignore your symptoms. You need to seek medical attention if you have any.
A few more questions. How does I think you addressed this, but how does exactly the COVID-19 vaccine affect the heart in any way? Does it directly impact the heart?
Well, the vaccine, of course, prevents people from getting infection entirely, or at least significant manifestations of the infection. I'm not sure that we can say that there is something that's so cardioprotective other than just prevention of severe manifestations, of which cardiac disease is certainly one of them.
And then maybe it's different than that. How does COVID-19 affect the heart itself? Does it infect the heart itself, or do you think it's more the actual reaction to the infection that's causing the heart problems?
A little controversial. It was initially thought, and there was actually autopsy studies that tried to show that the virus was directly affecting or directly in the heart muscle itself. And that has been refuted to the extent that it's really affecting the blood vessels that are in the heart muscle itself. And this speaks to why this disease has so many different types of presentations or associated with so many different symptoms in many different people. This is not exactly correct, but I sort of think of this infection as an autoimmune disease caused by a virus, much like something like lupus, where you can have many different manifestations in different people related to affecting these small, tiny blood vessels, right?
Yeah.
And so.
No, and I think the point that you're making there is exactly right. In the hospital, we have seen that patients who have COVID are more likely to get blood clots. So we're talking a lot about the cardiac manifestations or heart trouble that can come from COVID. But the other thing of note is that it can really impact the blood vessels. It seems to attack the blood lining, which causes an increased propensity or risk for blood clots. So I think as time has advanced in our treatment of these patients who've come in with COVID, we've learned to actually more often than not put them on blood thinners if we're suspicious at all that they may be at high risk for forming a blood clot that could be catastrophic if it ends up in the lungs or somewhere else that it shouldn't go.
Absolutely right.
This is a really tough one. I addressed my perspective on it a little bit, but I want to hear your perspective as well. This is a great question that came in. Is it hard to be a physician during a pandemic?
Yes, is the short answer. It's incredibly challenging. And obviously, I think the global population has seen the stress on the healthcare community, and not just physicians, obviously, but all care providers, everyone that works in a hospital setting has been stressed just from the sheer load of increased patients. Combine that with the catastrophic nature of patients who are hospitalized with the disease, and combine that with the emotional toil of not just caring for sick patients. I mean, you and I have been doing this for years, but also the fact that family members aren't allowed to be with their loved ones. All the restrictions on how we would normally interact, it's extremely stressful. And I think that as a healthcare provider, I mean, I think we're all dealing with that in different ways, but it certainly has its toll.
Yeah, absolutely. It's impacted the way we dress in the hospital, how we have to gown up, our interaction with colleagues, our interaction with patients. But I think it has had some positive impact as well. I think that telehealth, for instance, like everything else, has been adopted so much faster because of COVID. And it really has helped me take care of patients who otherwise can't get to the office easily enough. And with that, people are more facile with it, and it's easier for me to communicate with them and them to communicate with me. So I've enjoyed that part of medicine, and I'm hopeful that the pandemic will pass, and then we can enjoy the benefits of what we learned during this pandemic, but still take on these new technologies and really adopt them even more so.
Absolutely right. And there's so many things that we can utilize what we've learned as far as simple measures such as the precautions that we're all asked to take, whether it's wearing a mask, whether it's, contact precautions. There's a reason why the flu has not been as much of an ordeal as we were sort of expecting, having two serious viral outbreaks at the same time, right? These barrier and safety precautions that we are asking the community at large to utilize, they work. And so we've certainly learned that. But the telehealth portion, I think, is a beautiful example of how
your field, electrophysiologists
Absolutely.
in general, have been using tele capabilities for a long time. I don't know, for the audience, obviously, they may not know, but many of the devices that you put into people, such as pacemakers or monitors, can be monitored from far distances away. So you still have always had that information at your fingertips for a long time.
So even well before the pandemic, implantable cardiac devices have been demonstrated not only that we can follow patients remotely, but they're actually associated with better outcomes because you're following patients actually closer in doing so. But that technology and allowing us to essentially gather information remotely is what's driven all of this. And that then now applies to different ambulatory monitors, not necessarily implantable devices. It applies to now these virtual visits. There are many other technologies that can be utilized. They are being utilized in treatments such as heart failure. They're utilized in management for hypertension. And so this is all a
some positives that we should
field.
definitely celebrate.
Absolutely right.
Another question that came through, why does COVID target the heart, or is it the weakest organ for each individual?
I don't think we can certainly say that it's targeting the weakest organ in every individual. Certainly, pre-existing conditions increase your likelihood of infection. Now, does that mean that somebody with advanced heart disease is more prone to getting COVID manifestations of the heart? Well, is it the predilection, or is it just being ill to begin with and then subject to a fulfillment infection? It does appear, though, that COVID is unique in the degree or the likelihood of having cardiac manifestations, even in the asymptomatic population. So that is certainly true. I think we can say that with certainty.
Wow. So so say that again for everyone so they understand even more clearly.
What's unique about COVID as a viral infection or these chronic manifestations, whether it's a result of the inflammation that the virus itself causes or your own host immune response to that viral infection, there seems to be an increased predilection to cardiac manifestations in folks who have COVID infection.
Yeah, I think traditionally we've always thought COVID impacts the lungs. And one of the first things that we recognize when we started to see heart disease in patients who had COVID is that the COVID virus may have an opportunity to enter through the body through a receptor that is oftentimes treated by blood pressure medicines that we commonly use, or angiotensin receptor blockers. Lots of patients who may be on them, if you're at home, if you're on lisinopril, losartan, medicines of this sort of genre really are medicines that initially impact the same receptor through which COVID might be making an impact. And so there, at the beginning of the pandemic, there was a lot of apprehension about patients being on these medications. Now we've really learned that it's probably not a big risk to be on these medications. But again, a first clue. So outstanding question. I think a lot to still learn on this one.
Absolutely right.
Here's another great question that came in. Are you seeing patients with high blood pressure negatively impacted more than a patient without high blood pressure?
I don't know that you can make that leap. I mean, certainly we know that hypertension is a pre-existing condition that is associated with an increased likelihood of getting sicker associated with COVID infection. But I'm not sure that we can make that particular connection, other than the fact, what is very interesting, and I think we're only beginning to learn, I mentioned that this viral infection and the inflammation is associated with effects on the autonomic nervous system, the involuntary nervous system. And that certainly, as you know, of course, is associated with changes in blood pressure. So we do see patients who have recovered from COVID who then suffer from what's called a dysautonomia, problems with their involuntary nervous system, which relates to both blood pressure control, so patients can have more labile blood pressures, or heart rate. We've seen patients with decreases in heart rate more than normal and increases in heart rate more than normal. And so it's fascinating. We're still learning.
Yeah, I think that from my perspective, definitely we see COVID more negatively impacting those patients that have had chronic lung conditions or lung problems in the past, or other things such as obesity and diabetes also playing a role. But then with respect to high blood pressure, not as much yet. I think there's a few more questions that are here that I'm getting pinged on as well.
So the first one is asking if they have an artificial heart valve, are they more at risk for COVID complications or getting COVID?
Sure. So the exact question, just to repeat it, is that if a patient's already had an artificial heart valve put in, are they at higher risk for having complications from COVID if they were to get it? Fantastic question.
It's a great question. Certainly valvular heart disease, which obviously anyone that's had an artificial heart valve placed would qualify. And cardiovascular disease in general is considered a pre-existing condition for increased risk of getting sicker associated with COVID. Having said that, I'm not sure that we have any real data that says that someone in particular, for example, you could take somebody who has an isolated valvular abnormality that is corrected by replacement with an artificial valve, and they are otherwise now completely healthy now that they have a perfectly functioning heart valve and have normal cardiac function. Is that patient at higher risk? I don't think we know for certain, but I would think probably not as likely.
Right. I think that most of the people that we worry about in the absolute highest level of risk or concern are those people that are on immunosuppression drugs or people who have on chemotherapeutic drugs. Those are the people we worry about a lot. Those patients that have had a traditional valve operation are probably at a little bit higher risk, but not in that same highest risk category that we think about. But nonetheless, probably for all of those patients, we'd be cautious.
Sure.
And oftentimes our patients that have valve replacements in the past are older or elderly, and so we worry about them a little bit more than we would otherwise. I think there's a few more questions. Sorry, go ahead.
People have stayed home for so long, and now some have started to receive their vaccines. Does this mean that they can return to living their life as before and traveling both domestic and international?
Great question. So I think that with the advent of the vaccine, all of us are optimistic that we can get back to our regular lives. And the question really asks, once they've gotten the vaccine, are we back on the road to a more normal life? What's your perspective on that?
So the answer is not yet, I think. And that's just in keeping with current guidelines. Now, obviously, there are country to country differences in how they're looking at this and what their restrictions or their individual requirements are, whether it's testing before, testing afterwards to come back in. There's not been a formal statement regarding patients who have received a vaccine. However, just this week, it has been speculated that in patients who have had successful vaccination may not require testing before and after a domestic or international trip.
Yeah.
This is not in formal guidelines yet.
My perspective is probably that we're cautiously optimistic that with the vaccine, there can be a greater trend towards normalcy, but we're not sure. And we don't know how long the vaccine will last and whether it has to be an annual vaccine as well. But it's definitely a step in the right direction for sure.
Absolutely right. What we do know is that these vaccines are incredibly effective. What we don't know, obviously, there's been a lot of talk about some of these variants and what the protection afforded by the vaccine, if they will apply to them. Thus far, we think they will, but we're still learning. And we don't know how long immunity is conferred after receiving a vaccine. And that we need to demonstrate before we can make long-lasting recommendations.
I think there's a couple more. Go ahead.
So another question is, why do some spouses or partners get COVID and others do not? And also, why do some get so sick and others just have some very small symptoms from it?
Two outstanding questions. So one is why does one spouse get it and the other doesn't? And then the second part is, why do some people become so acutely sick from it whereas others have little to no symptoms at all?
So both of these questions are an unknown. Though, if a spouse doesn't get it, you just wonder how much contact they're actually having. So maybe not liking your spouse is actually protective. Obviously, the bigger issue is not whether or not they have, any conferred protection from not getting the infection. It's probably more likely their ability or their tendency to have symptoms associated with the infection. And so because we're not actively testing patients or folks who have been exposed for previous exposure, and those tests, in fact, are not very good. I'm referring to, of course, the antibody test for prior COVID exposure. We do know that many patients have asymptomatic infection and have a exposure and can turn positive. But we also know that patients who are asymptomatic or have less disease lose that antibody level faster. And so if they're not getting tested acutely, just because you have a negative test a month later, 3 months later, doesn't necessarily mean you weren't exposed and didn't have an asymptomatic infection. Regarding the why some people get sick and other people do not, honestly, we just don't know what the individual predisposition, why I get sick and you don't is.
It may
no
come
idea.
down to the immune response
Of
that we
course.
all have that's unique, as well as how much virus exposure we had in the first place.
Certainly.
But I think there's so much that we need to understand and study more as time goes by. But great perspective. I know there's another question too that they wanted to ask as well. Go ahead.
You mentioned the blood clots potential from COVID. Is someone who is on dual platelet therapy less susceptible to getting the blood clots related to COVID?
A great question. So basically, we know that the virus seems to attack the blood lining, which causes an increased risk or predilection for blood clots. And we do think that aspirin and or Plavix or other antiplatelet drugs can help prevent some of the blood clots, but not as they're not quite as effective as other even stronger or more potent anticoagulants that you may see commercials for on TV, like Eliquis or Pradaxa. But the physician that's treating the patient with COVID is most likely the best judge for that person's individual situation to make sure they can give individualized, personalized recommendation as to what blood thinner to be on, if at all, if they've had COVID.
For patients who've had COVID and we're talking about these long-term effects, is there a time duration which we would no longer associate those symptoms to COVID, or a typical time frame in which we would expect those long-term effects to be seen?
So great question. The question is, how long can the potential impact of COVID be there, and how long can we attribute things to COVID?
And of course, the answer is we don't know, right? Because we certainly can see patients with symptoms that are lasting a long period of time, like our mutual patient, for example. But at a certain point, is it attributable to COVID? Is it attributable to something else? I think it depends on what it is you're talking about. And are there other reasons? So for example, we've talked about the risk of blood clots and having blood clots in your lungs or precipitating a heart attack or a stroke. At a certain point post-COVID, is it that predilection, or is it just your own innate risk for having that disease? The answer is we don't know. But that gets to what we are hoping to learn, is what really constitutes long-term manifestations. What that real time course is, this is still too early to say.
Great question. I want to actually, at this point, as we're ending the hour here, first of all, thank you, Rahul. It's just, Dr. Doshi, it's a privilege to be around physician scientists like you at HonorHealth that are really pushing the envelope and making sure that each and every patient has the most individualized, comprehensive treatment for cardiovascular care. And I've learned a lot from you over the last several months, and along with our other physician leaders. I would also thank the audience tonight for joining us. We're really excited that you had an opportunity to hear from us. And I would encourage you again that February is Heart Month, and it's incumbent upon all of us to make sure that our loved ones seek care to make sure that they don't develop heart disease. I will mention again that 50% of all cardiovascular deaths could be prevented if we can just proactively make sure that we're seeking attention for any symptoms that we have, and we're addressing any risk factors like high blood pressure, like high cholesterol, sedentary lifestyle. And really, there's so many techniques, technologies, medicines that are out there that can help improve our ability to treat heart disease and prevent heart disease. And so thank you guys for joining us. COVID and heart disease is obviously something that's on our mind quite frequently, and I think we're learning a lot about it. And so it's just remarkable that in a span of only 1 year that we have this much understanding of it, and even more. And so I'm very impressed with our advances thus far. What are you most, I'll just end with this, at HonorHealth, you are involved in many clinical trials that are focused on COVID. And what is the one that you're most optimistic about, and what do you want to see in the next year? Maybe that could be our parting last thing for the night.
Absolutely. I would actually say it's not even from the clinical trial standpoint. Obviously, clinical trials are designed to answer a more specific question, but what can we learn in a global sense? So at HonorHealth, in the spirit of being proactive, and we're certainly not alone in this. This is being done across the country as the need is clearly there. We are going to create a specific COVID and cardiac manifestations clinic that focuses on patients that have cardiovascular manifestations of this disease, so that we can continue to learn about how this interplay continues and exists even as time goes by. And so I'd say stay tuned.
Excellent. Well, Have a great night. Thank you for joining me,
Thank
Dr.
you.
Doshi. Thank you to all in the audience who are joining us tonight. We appreciate your time. Please reach out to us at HonorHealth if you have any questions or any concerns, or if we can help out in any way. And stay heart healthy, and we'll see you again soon. Good night.
Stay safe, everyone.
Thanks, Dr. Doshi.